to be apa nama ni, you need to cover that very well. When you 5 later on, so your that the additional part would be the management and investigation. Okay, so hopefully of these two cases, you will have the idea on actually how to approach a child who came with the edema. Okay, so I am a nephrologist, so not all patient with edema equals renal problem, not equals nephrotic syndrome. Okay, so we want to actually make you to think out of box. Okay, so edema is not always kidney, it's not always liver, it's not always cardiac. So that's the aim of this session. All right, okay, so we can start off with the first case. Okay, so I want all of you to participate this. So I'm going to choose your name randomly from the list. Okay, so otherwise I know it's 3 o'clock in the afternoon.
Okay.
So we expect you to know, because when you is actually these are part of the things that you are expected to know. Okay, fine. Got that.
Right. Assalamualaikum. Very good morning. Very good afternoon. Sorry. My name is Muhammad Mustaqim. I will present about nephrotic syndrome. Next. Okay.
Control slide. Siapa yang control slide? Okay.
Ashfi.
Alright. You have to speak up, Mustaqim, sebab your voice is quite soft. Kena cakap dekat sikit dekat you punya microphone. Okay.
Alright. So, history taking of nephrotic syndrome. Actually, this is a real case. By my supervisor, he provided me with the nephrotic syndrome case from the pediatric ward at HUSM. So here is the case. The patient name is Muhammad Dafi Hadik bin Hafiz. He is 7 years, 10 months. He is Malay and live at Kota Baru, Kelantan. Next. So the chief complaint is a facial puffiness and peripheral edema. Next. So here is a history of presenting illness, which I call his mom on the phone call, and then I read the history. So presented with unresolved facial puffiness for 8 days, starting from Saturday, 21 of March 2021. The symptoms start at night and progress during day with presence of periorbital edema. No pain was complained by patient, but he felt uncomfortable. On day 4, edema progressed into peripheral edema when upper limb and lower limb involved. No abdomen distension is reported by his mother. 1 week before shift complaint, patient presented with intermittent fever for 4 days. Fever start at night and resolve in the morning. Temperature of the body during fever is unknown, and it was noticed as patient's body is warm. Patient also had headache during fever, and headache is resolved with paracetamol. No shivering complained by the mother. His mother denied any cough, flu, and presence of rash during the fever. Next. So here, when the patient presenting me with the case, I do differential diagnosis, and also I include the sequelae of nephrotic syndrome. The first one that differential diagnosis come with my mind is nephritic syndrome. Patient, but I exclude it by asking the patient about headache, because headache associated with high blood pressure. Nephrotic syndrome have high blood pressure, so patient do not complain headache during the edema symptom. And I also asked about the urine color. So patient no change of urine color, no blood is present in the urine, and no significant decrease in urine output reported by the mother. For anaphylaxis reaction, because the edema also have differential diagnosis with anaphylactic reaction. Patient do not have history of stung by insect. Patient do not develop any allergic reaction to food. The edema is not associated with increased redness and itchiness. For sequelae, because nephrotic syndrome develop a few complications. One of it is thromboembolism. So I asked about is there any varicose vein at the legs, so the patient do not develop varicose vein. Patient, so the other sequelae is a pulmonary embolism and pulmonary edema. So I asked about the shortness of breath, chest pain, and tachycardia. Patient do not develop these symptoms. And the other one is abdominal pain, because the sequelae of nephrotic syndrome is peritonitis. So I asked either patient develop fever and abdominal pain. Fortunately, patient do not develop fever and abdominal pain. Next. So the systemic review, gastrointestinal symptom, during the onset of the symptom, patient vomiting with gastric content after eating rice during onset of the symptoms. No weaknesses, no fatigue, no fever are reported by the mother. The volume of vomit is little as told by the mother. So I think about maybe patient get gastroenteritis, but since the volume is not little and it is only once that the patient vomit, so it might be acute gastroenteritis. So the other system that I asked is about nervous system, cardio system. None of the system is remarkable. Past medical history, the admission history, patient was admitted into pediatric ward on 21 March 2021. Patient was inserted with urinary catheter for urine specimen collection and urination. Medical history, 2 years ago, patient presented with generalized idiopathic urticaria for 2 weeks.
Sekejap, Mustaqim.
Yes.
Mustaqim. This one was the patient in we put the CBD. I cannot recall we put the CBD in this patient.
CBD.
Catheter. You tulis itu urinary catheter for specimen collection.
Yes.
Is that what the mother bagi tahu?
Mother dia bagi tahu.
Okay, I think we did the in and out tu tadi ni. We did in and out catheter. Fine.
So medical history, 2 years ago, patient presented with generalized idiopathic urticaria for 2 weeks. The symptom resolved with hydrocortisone cream given by private clinic. No respiratory symptom like shortness of breath is present. And then at the same year, patient presented with rhinitis of unknown duration. The presentation progressed into production of pus at the years. He received treatment from private clinic with given of antibiotics and the symptom resolved. The immunization history, patient received immunization up to his age. Next. So pediatric history, her mother was not presented with any disease that would complicated the pregnancy. Example of the disease I asked is diabetes mellitus, preeclampsia, intrauterine infection. She did not have history of miscarriage. Patient was born on 39 weeks with weight of 3.1 kilogram through normal vaginal delivery. No birth complication reported by mother and the patient. Patient was born at Hospital Raja Perempuan Zainab II and no admission after birth. Next. Nutrition history. Patient received exclusive breastfeeding until 2 years old. Weaning start at age of 2 years old. After they receive the breastfeeding, patient do not develop any stunted growth or reduction of weight along 2 years of exclusive breastfeeding without weaning and after that. Now patient do not have reduction of food intake and reduce of appetite. Patient weight is 24.9 kilogram and height 170 cm. Weight based on the percentile is below 50 and height also below 15 percentile. Next. Next. So as you can see here, this is a percentile. Next. So developmental milestone. Patient do not have late development as claimed by her mother. Next slide.
based on this growth chart in front of you, you kata tadi, right? Mustaqim boleh dengar ke?
Tak boleh sekarang. Tadi putus-putus.
Okay, sorry. Okay, so just now you go back to the growth chart tadi. Slide. Pergi ke growth chart. Okay. Okay, just now you say the patient punya height and weight is actually at the 50th centile kan? Okay, you kena unmute yourself. Okay.
Below.
So I just want to know how do you... Okay, below. So what does it mean?
Patient
Does it mean that dia tak normal ke? Dia tak driving ke?
tak, sebab dia macam dekat-dekat dengan 50, dia bukannya exactly below.
I know. Tapi how do you interpret? You nak kata dia ni normal ke? Tak normal ke? Is it thriving or not thriving? So bila kita plot on the growth chart ni, the reason why we want to plot is we want to see how the child is thriving ke tak thriving. So my question is, how do you define a normal, so-called normal child? So dia ni growth dia normal ke tak normal?
We have to see the from the start, the growing every year. Do the growing
correct.
going upper or lower?
Okay lah, let's say, okay, you're correct. It should be a serial punya measurement. Tapi let's say if the serial one has been that around that line. Maknanya you kata just below the 50th centile. So has been around that for the past since he was born. So is it normal ke tak normal?
I'm not sure lah, doktor.
Okay, siapa Aina Balkis. Aina Balkis. So would you like to answer that? Okay.
I'm not sure too, doctor.
Okay. So when you look at the growth chart, okay, so growth chart comes in, this one is a CDC, CDC, you can see. The WHO also has their own growth chart. Actually, at the moment, we are using the WHO punya. So if you look at the growth chart, on here, if you can see, whether you can see or not, I'm not quite sure. I think the bottom one is the 5th centile, kan? 5th centile. The
Yes.
bottom punya line, kan? WHO punya is 3rd centile. So anything that, and then the above one is 97th centile. So when we say this such as percentile is actually based on the age and sex of the patient. Okay, so you kena tengok umur dan the jantina of the patient in order to get the correct measurement. So when we say it's a normal growing or normal centile, is actually between the 3rd and the 97th centile. Tapi kalau you based on this chart, that will be between 5th to 95th centile lah. That is so-called the majority of the children with the same sex and age would fall under that range. It does not mean they're normal, tak semestinya, because you can have a patient to start off, let's say umur dia umur dia 7 tahun. Okay, initially the weight is, for example, at the 50th centile, and then after at 8 years old, dia punya weight dia tu cross 2 percentile punya line. So from 50th centile jadi say 10 centile, for example. So that is, kalau you kata definition, is still within the normal, tapi once the growth actually cross the 2 centile, once the growth actually cross the line actually cross 2 centile, then it should raise the alarm that something is not correct. Kejap, siapa yang tak mute ni? Siapa yang tak mute? Okay, somebody please mute your phone, your microphone. Okay. Alright, so that's what it means. Okay, sama macam if you're talking about a child who is, let's say, obese, the weight is above 97 centile. It actually, yes, it is what we call outside the normal range. Okay, outside the normal range. Tapi, so it is representing only 3% of the population with the same sex and age. So in a way, if you nak kata abnormal pun not necessarily, but they are the minority of the group. Either they are above or below the percentile. Okay, understand or not? Okay, so that's why you are correct. Sepatutnya kita kena ada serial measurement of the weight and the height. Then you can make a conclusion. That's one. Second thing is you need to differentiate anthropometry ataupun percentile ni between the anthropometry and also the blood pressure percentile. Blood pressure percentile has its own percentile. And when do we say it's the normal percentile? Is actually when the blood pressure is between 50th until 97 centile. 50 until 95th centile. Anything below the 50th, below 50 percentile is hypotension. Anything that's above 95th centile is hypertension. So it's not the same as anthropometry. Tadi kita define anthropometry, anything that's actually below the 3rd percentile or above the 97 percentile is so-called not normal lah. Okay, so don't get it mixed up. That's my point. Okay, all right, continue.
Next. So this is a developmental milestone. Patient do not have late developmental as claimed by her mother, and his developmental is same as his older sister. Patient start walking at 1 year, 9 months. Patient start toilet train at age of 4 with not using diapers. Start know how to read during primary 1, 7 years old. Next. Family history. Patient is a second child of the family. Patient have one older sisters, which is 10 years old, and younger brother 2 years old. No history of inherited disease or malformation during birth reported running in the family. No history of chronic disease such as diabetes, hypertension, chronic kidney disease, or heart attack running in the family. And then the social history, patient lived in the wood house at Kampung Gondermit, Kota Baru, Kelantan. His father, Mr. Hafiz, is 33 years old, worked as a paddy planter, and his mother, Madam Nordini, is also 33 years old, worked as an online businesswoman. Dafi received education at SK Gondermit. He does not attend school for 3 weeks due to his disease, which is fever and the edema just now. He is quiet and shy person. Next. This is drug history given to the patient. So I asked the mother to take picture of the drugs. This is so I read the label. I do but I do not know how many times the drug is given in a day. So patient was given 250 mg of tablet penicillin 5, 25 mg tablet of spironolactone, 5 mg of tablet of prednisolone, 600 mg tablet of potassium chloride. No intravenous drug is given to the patient. No drug allergy is developed by the patient. Next. So, physical examination of nephrotic syndromes. So, the first is we need to do a general inspection. So, appearance of behavior of the patient who have nephrotic syndrome, the child is observed in the environment. Child's level consciousness is intact. Altered consciousness of the child indicate as complication of electrolyte imbalance due to renal failure. Apparent swelling of the limb and facial puffiness are noted when patient have nephrotic syndrome. Nutrition status is good and the patient growth is intact. Refer to this patient lah. If there is a complication of chronic renal failure, there will be growth retardation. Pallor present in the child due to loss of transferrin. Transferrin is an iron-binding protein. Lymph nodes. No lymph node enlargement is seen in the child. If present, it is associated with secondary nephrotic syndrome causes such as leukemia and lymphoma. Next. So the vital signs. Temperature.
Sekejap, Mustaqim. Can you repeat your statement tadi? Yang last statement you kata secondary nephrotic syndrome, saya tak, I lost that sentence.
Go back to the next, last.
Okay, you kata apa tadi? Yang pasal second. Okay.
Secondary,
It is associated with second.
If present, if present of the lymph node enlargement, there might be a secondary nephrotic syndrome causes by leukemia and lymphoma.
Very, very, very rare lah. Okay, very, very rare I have to say. But yeah, when you talk about nephrotic syndrome, there is primary and secondary. Okay, so primary is within the kidney itself, idiopathic nephrotic syndrome. Secondary is secondary to other condition lah, as you said. Lymphoma can cause, yes, correct, but not common. The common one in our community is more like lupus nephritis, SLE, HSP, IgA, so those are the common ones. So, but okay lah, it's not wrong, but it's not common lah. Okay, all right, fine, proceed.
Next. So the vital sign, temperature, it may or may not elevated. If elevated, it is most likely due to associated complication of nephrotic syndrome such as infections, fever lah. Because nephrotic syndrome can cause infection due to immunoglobulin loss from the body. Respiratory rate is normal and patient is not shortness of breath, but it may elevated if patient develop pulmonary edema or pulmonary embolism. Pulse rate is normal. Hence, peripheral swelling due to loss of albumin in nephrotic syndrome is noted by presence of pitting edema. Leukonychia, whitening of the nail bed, is present in the child due to hypoalbuminemia. Next. This is a systemic examination. So there are two examinations that we can consider in nephrotic syndrome, which is abdominal examination and respiratory examination. So abdominal examination, inspection, on close inspection, there is no abdominal extension in this patient, but it may have abdominal distension due to peritoneal edema. Palpation. While palpating, the child is observed and he is not in pain. Severe peritoneal edema may lead to pain and make the child uncomfortable. Assessing for shifting dullness, if there is a peritoneal edema, so there is a shifting dullness, the presence of shifting dullness is suggestive of peritoneal edema. It is not present in the child. In the child, it doesn't present peritoneal edema. Assessing for fluid trails, no fluid trail is noted in the child. So this is how you want to access shifting dullness and access fluid trail wave. So shifting dullness, this maneuver is performed with the patient supine, and then you percuss from the abdomen, from the flank, for the flank with the point of transition from tympani to dullness node. The patient then roll on her side away from the examiner, and the percussion from the umbilicus to the flank are repeated. So it is positive when the ascites is present, the area of dullness will shift to dependent area. The area of tympani will shift toward the top. So this is how you would do the shifting dullness. And then a fluid wave, have the patient lying supine. The patient are assessing place one or both hands. The ulna, this one you do at the patient abdomen. And then position in the patient mid-element playing with the slight pressure. The examiner place the fingertips of one hand along one flank, and with the other hand with firmly gives a sharp tap along the opposite flank. Positive test, the examiner is able to detect a shock wave of the fluid moving against the fingertips pressed along the flank as the fluid is pushed from one side of the abdomen to the other side of the force of the tap along the opposite side or the opposite flank. I guess if you want to know, if you want to see here, you can look at the YouTube video. So respiratory examination. For inspection, The child is observed particularly for the respiratory rate and word of breathing. The respiratory rate is normal at 20 breaths per minute. No sign of increased work of breathing such as difficulty speaking. Palpation, the apex beat is palpated and is heard at the fifth intercostal space in the mid-clavicle line, which is normal. Leftward displacement of apex beat is indicative of right pleural effusion. And rightward displacement could be indicative of left pleural effusion because pleural effusion may present in the in nephrotic syndrome. Auscultation, on auscultation, the breath sound is normal. If quiet, breathing sound is heard, it is suggestive of pleural effusion because there is a content of fluid. Or if added sounds such as coarse crackle are heard, it is suggestive of pulmonary edema. Vocal resonance in this patient, vocal resonance is normal, and abnormal vocal resonance of decreased volume suggests the presence of fluid and air outside the lung, for example, in pleural effusion. Next.
Okay, I want to comment a bit since you are talking about these findings. Can you go back to the previous slide? Previous slide. Hello, previous slide. Okay, all right. Assessing for vocal resonance, okay, is actually vocal resonance is when you actually ask a patient to actually say 99, which is a high pitch sound, okay. And the aim of doing vocal resonance or tactile parameters is you want to see whether the transmission of the air is better or not good with the air. With the transmission of air is better through a solid structures, which means in this case would be a consolidation lung, okay, or consolidated lung. So in a normal condition, when you do the vocal resonance, ask the patient to say 99, normally you don't hear the 99 clearly. Okay, you will say it's what we call muffled 99, 99, 99. So it's not 99. If the patient, the reason for that is because the lung is filled up with air. So air is not really a good conductor for sound. So when the patient has consolidation, pneumonia lah basically, the air is transmitted better through a solid structure. So when you get the patient to say 99, you will hear 99, 99 clearly. So we will report as increase in vocal resonance ataupun increase in tactile parameters. Tactile parameters is you feel vibration, you feel the vibration. Vocal resonance is auscultation. Okay. So in normal condition, kalau vocal resonance is either increased vocal resonance or not. That's all. It doesn't mean that vocal resonance tak increase, dia tak normal ataupun dia it can be normal or it can be it can be not normal in the case of pleural effusion. Contoh, kalau pleural effusion, your vocal resonance will not, in a way, it will not be affected per se, because the consolidation is not there. It's just the fluid, right? The effusion actually covering the lung. So reason I have to emphasize this because many students, not only students, MO or even registrar also they have the wrong concept of this vocal resonance. So bila you dengar vocal resonance tu, in normal condition, you can appreciate dulu how it sounds like, which is muffled, okay? Muffled in normal condition. So whenever you hear vocal resonance increase, which is what we mean by increase is it's not 99, kuat. It's 99 clearly. Okay, it's not the volume, it's the intense, it's the clarity of the sound. Okay, so hope that actually clear the misconception. All right, okay, move on. So in this case, knowing nephrotic syndrome, you're going to present pleural effusion, there will be the vocal resonance in a way will not be affected basically. So it's just reduced by sound and dull on percussion. You may have deviated or midline. That's all. Okay. All right. Okay. Continue.
So how are we going to diagnose nephrotic syndrome? So we need to know the definition of nephrotic syndrome. Nephrotic syndrome is a clinical syndrome characterized by tetrad, which is first edema, second proteinuria, which is 40 milligram per meter square per hour, or more than 1 gram per meter square in a 1 day, or an early morning urine protein creatinine index is more than 200 milligram per millimole, or more than 3.5 milligram per milligram. Hypercholesterolemia, and last is hypoalbuminemia. Next. Thank you. Next.
Dah ada ya?
Tak, sebenarnya ada before dia ada.
You tertinggal slide. Okay. So apa namanya?
So this
alright, okay. So can you summarize? Okay, can you summarize?
So first, doctor, we go into how to diagnose first. I think this is important too. So this is pathogenesis and clinical finding of the nephrotic syndrome. So as you can see, membranous glomerulonephritis, minimal chain disease, diabetes mellitus. This will cause, and then these four mechanisms: membranous proliferation glomerulonephritis, lupus glomerulonephritis post-infection, IgA nephropathy. It will result in a damaged glomerulus. So the point is the glomerulus is damaged. So when glomerulus is damaged, more specifically at the pedocyte, so the pedocyte cannot hold the protein for escaping through the blood vessels. So this will cause the protein to escape through the glomerulus.
Second, you kena guna. I think kalau when you explain a diagram, is actually good for you to annotate ataupun use your pointer. You boleh guna you boleh guna your pointer. So just left click tu ada annotate. Annotation. Belah kiri and ask to annotate.
Setting ke doktor? Sekejap doktor.
Ada tak annotate okay. I don't know whether you can see or not. Ni saya punya pointer. You can see or not? My pointer.
Yes.
Okay. Alright. So I think just to make things simplified, the slide looks very busy. Right. So I just explain on your behalf. Boleh?
Silakan.
Okay. Alright. This is a concept that you need to understand in nephrotic syndrome, okay? Because just now Mustaqim dah explain in terms of the definition, okay? Just now kan, the previous slide ada definition, which is the hypoalbuminemia less than 25. Actually, the current definition is actually now 30 gram per liter of serum albumin. And then the nephrotic range proteinuria, which is defined by more than 40 milligram per meter square per hour ataupun more than 1 gram per day. Adult, they take it 3.5 gram. So don't get it mixed up. But adult also ada nephrotic syndrome, but a different type of nephrotic syndrome. And then generalized anasarca or generalized edema plus hyperlipidemia. Okay, that's the definition for the criteria for you to diagnose nephrotic syndrome. You can have nephrotic range proteinuria, tapi they are not what we call idiopathic nephrotic syndrome. It's just nephrotic range proteinuria. Macam Richard dia tulis tadi lah, secondary nephrotic syndrome, SLE ataupun post-strap AGN ataupun IgA nephropathy, they can have nephrotic range proteinuria, tapi serum albumin dia normal. There is no hyperlipidemia. So you don't group that as idiopathic nephrotic syndrome. So generally speaking, bila kita kata nephrotic syndrome in children, we are talking about idiopathic nephrotic syndrome. Okay, please remember that terminology. So pathogenesis of nephrotic syndrome, as the name suggests, it is idiopathic. Maknanya you don't know what is the underlying cause basically. But more evidence actually show that the podocyte is actually where the problem actually starts. Podocyte, Okay, so the podocyte, you know that in nephrotic syndrome, most of them will have what we call minimal change. Minimal change disease, which actually involve the flattening of the podocyte. or effacement. That's what the term that we use. So that's when the effacement or the flattening of the podocyte occur, that will impair the filtration process that normally present in the kidney, right? So you have to go back to the physiology of your lecture on the normal physiology of filtration. Okay, so I just make this, okay, there is terminology here. Okay, so you can see here, okay, the effacement. So when the effacement occurs, so that's why your permeability will also be affected as well because of the inflammation process that actually can occur. Whether or not it has a component of what we call the inflammatory mediators, yes, definitely. So that's the reason kita guna prednisolone, kita guna MMF, kita guna cyclosporine, because they are immunosuppressant. So all these multifactorial punya factors will contribute to the effacement of the podocyte, leading to leaking of the albumin through the filter. All right. So when the proteinuria is a lot, okay, in the tubules, so you have a significant loss of albumin. So that will result in hypoalbuminemia, right? So hypoalbuminemia, we know that albumin is one of the main components to dictate the oncotic pressure. So oncotic pressure, hydrostatic pressure, all right? So hydrostatic pressure favors the outside, okay, pressure, pull towards the extravascular. Oncotic pressure actually pulls the fluid inside the vascular space. So when the oncotic pressure is low, so there will be more net diffusion or net filtration that from the intravascular to the extravascular, go to the third space. So that's why the edema occur. All right. So that's the postulation, what we call the underfill. Pernah dengar underfill? Are you going to talk about underfill now? See, this is the underfill we're talking about. Okay. So the underfill is basically referring to the edema. Why the patient in nephrotic syndrome develop the edema? So through the mechanism as we discussed just now, because of low oncotic pressure, blah 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 blah. There is another theory which is not in this table. This one you taken from where? 2013 should be there already, you know, the overfill.
Take from internet, Google image.
Okay. So there is another theory, what we call the overfill. Overfill theory is actually both theory try to explain kenapa both patient develop edema. Just now kita kata patient develop the edema because of the low oncotic pressure and blah 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 blah. Okay, the mechanism just now. But majority of the patient, they have edema, tapi they do not develop hypovolemia. So bila kita kata tadi low oncotic pressure, basically it referring to hypovolemia, low blood pressure. Majority of nephrotic syndrome in children, they do not come with hypovolemia, they come with euvolemic, normal blood pressure. So kalau kita guna this theory, that why it doesn't explain kenapa. So that's why the overfill theory comes in. So they basically, the hypothesis that was put up to explain why this patient develop edema is because of the other mechanism, what we call the high intake of sodium in nephrotic syndrome, the upregulation of the ENaC channel. We call it ENaC channel, epithelial sodium channel at the distal tubule. They also have resistance effect to the atrial natriuretic peptide, ANP. Okay, pernah dengar ANP? So ANP is a peptide that is released from the atrial of the heart in order to promote diuresis. Tapi dalam nephrotic syndrome, for some reason, we do not know the cause yet, for some reason they are resistant to ANP. So that's why the ANP, bila kita measure in patient with nephrotic syndrome, it tend to be high. Tapi for some reason they develop the edema. Okay, so those group what we call the overfill. Majority of the time, patient is actually overfill rather than underfill. Okay, understand? Okay, so these two concepts you kena faham sebab your next management would be either to give fluid or to give diuretics. Okay, kalau you still up assess patient, oh you think this patient edema, so kena bagi diuretics lah. Then kalau you so unlucky patient ni may looks edema tapi dia underfill, dia hypovolemia, you bagi diuretics, the patient may die. Ataupun on the other hand, you rasa patient ni edema. So Dr. Ikram kata, oh patient ni maybe overfill. So apa nama ni? So we need to give diuretics. Apa nama ni? So kalau patient tu overfill, you bagi apa nama ni? Albumin. Okay, you bagi albumin, they will go into overload. So that's why kena assess properly from the clinical point. You kena understand this concept. Okay, any question?
So doctor, to access underfill and overfill, blood pressure measurement is important lah, right?
Okay, yes. That's a very good question. Okay, clinically kita kena because apa nama ni not all centers can actually perform what we call monitor the cerebral central venous pressure, the CVP. Okay, kalau you overload, so your CVP will be high, your GVP will be raised, your heart will be tachycardic, the BP would be high, the apa nama ni, so that's indicating you are overfill. Tapi kalau underfill, the BP will be low, white pulse pressure, your perfusion will be apa nama ni, poor kan, delayed capillary refill. So that's on the clinical assessment. Tapi studies have shown you can actually show from the measurement, from objective assessment by sending urine electrolytes. Okay, you may have heard what we call the fractional excretion of sodium. I think last time I spoke about fluid therapy kan? Is it your group? Fluid therapy, the big group. Fluid therapy in children. Dehydration.
Last pediatric.
Okay. Yes. So that's actually for you to assess whether the patient is under ataupun dehydrated lah in a way, under volume or over volume. So you can send urine electrolytes, you can send the sodium, you can send the renin level, aldosterone. Tapi that one will take 1 or 2 days to come back. So at the end of the day, because you need to decide patient datang kat kecemasan A&E, whether this patient need fluid or the patient need diuretics. That's why you have to rely on the JVP, on the blood pressure, on the clinical assessment. Okay? All right, go on.
Next. So this is a differential diagnosis. Just like I said in the history, but we just repeat it. Differential diagnosis is first nephritic syndrome. It's like similar to nephrotic, but it's different. Different clinical. So nephritic syndrome, the reason to rule out is because the patient don't develop hematuria, no high blood pressure. So the high blood pressure, usually we want to see from history is history of headache, because patient with presence of headache, we must suspect of blood pressure, high blood pressure. The urine color is not changing to dark yellow. Do not reduce in urine output. So congestive heart failure also may present with edema. No respiratory distress, no tachycardia, no tachypnea to patient, no displace of apex beat, no chest deformity, and no gallop rhythm. For anaphylaxis, we have to see the causes of anaphylaxis to differentiate. So one of the causes is stung by the bees or by the other parents, other insect. Exposure to allergen like peanut and so on. No flushing, no wheezing, no respiratory distress. Liver cirrhosis. No liver failure stigmata. For example, liver failure stigmata is Dupuytren contracture, encephalopathy, hand flap, spider nevi, caput medusa, no jaundice, no itching. Next. Okay, so this is investigation that we need to do in nephrotic syndrome. First, urine test is a quantitative urine protein excretion to measure the protein creatinine ratio or 24 hours urine protein. B, urine dipstick test. This is a qualitative protein measurement that we see from changes of the colors of the indicator. So there is like we just learned at the preclinical lah. Positive 2, positive 3. That's indicate how severe is the proteinuria. And then urinalysis we can do to see also a quantitative. We can see albumin, what kind of protein in the urine. Next, urine microscopic and culture. We want to see is there any red cells, red cell cast or fatty cast. Sorry. And then blood test. Blood test first a full blood count to look for HB, maybe we don't know, maybe anemia, and hematocrit level, renal profile, urea, electrolyte, creatinine, serum cholesterol because patient might have hypercholesterolemia, and then liver function test, particularly on serum albumin, and then other investigation to exclude SLE because SLE is a different management from other nephrotic syndrome causes. First, we can see anti-nuclear factor or anti-dsDNA. Complement studies, we can see the quantity of the complement to exclude SLE. If an SLE is present, the complement is low. And then ASOT titrates to exclude post-streptococcus glomerulonephritis. And then the other one, renal ultrasound and renal biopsy, only indicated in steroid-resistant nephrotic syndrome. Next.
Saya nak comment sikit. Okay, on the slide. Okay, you go back to the slide. Go back to the slide. Okay. Alright, so you're correct. Okay, you need a patient who came in with a nephrotic syndrome. We have to make sure that it is not secondary. So as you mentioned there, the most common in our population will be the SLE, the CHESP, nephritis, IgA. ASOT is to assist the diagnosis of your post-strep. If the origin is from the throat, okay, you're going to have to remember the group A beta hemolytic strep has two origins, either from the throat or from the skin. If the origin from the throat, then you will have, majority of the time, you will have the positivity of the ASOT. Tapi if the origin is from the skin, most of our patients yang ada impetigo, yang berkudis kaki itu, the ASOT will be normal or negative. Okay, so it does not exclude post-strep. Kalau ASOT negative, it actually have to assist you in diagnosing of post-strep. So you have to remember, because sometimes when I ask, oh, ASOT negative, so it's not post-strep, which is not correct. Because our patient mostly is actually, kalau you tengok, mostly is a skin punya problem lah, rather than throat, right? Pharyngitis. Okay, okay, proceed.
Next. So this is management outline of the nephrotic syndrome. General management from diet, adequate calories, no added salt when child has edema, because just now doctor said to avoid overfill something. And then normal protein diet. We have to give protein to the patient because patient may lose protein, but not over lah, normal. And then we give
no added salt though. No added salt is because of the things. No added salt. That's about kalau you makan salt, okay, the problem patient now has edema. So kalau you take a lot of salty food, the patient will feel thirsty. When they're thirsty, they will drink more water. So it's going to make it worse. Satu. And then when you do less salt, is sodium. So when you take a lot of sodium, so you will retain more water. So that's another reason. Yeah, so that's the reason during the nephrosis state, you will actually add no added salt ataupun low salt diet. Okay.
Okay. So penicillin 5, as you can see from history, doctor given penicillin 5 to the patient. It is recommended at diagnosis and during relapse. In the presence of gross edema, it can avoid the patient from getting infection, as a complication of the nephrotic syndrome is infection. And
Penicillin V
then,
bukan penicillin fast, penicillin V. Sebab
penicillin
dia ada
V.
penicillin G. Penicillin V ni is oral. Penicillin G, which is benzyl penicillin, is IV ataupun IM. Okay.
Alright. So third is assessment of hemodynamic status. Check for sign and symptom of hypervoluminemia, abdominal pain, cold periphery, poor capillary refill, poor pulse volume without low blood pressure. Hypervolemia, vessel lung creptation, bronchi, hepatomegaly, hypertension, and fluid restriction in a chronic edematous state. And then diuretics, we can give furosemide if very edematous, but please make sure that patient don't have evidence of hypovolemia. If patient have hypovolemia, we give diuretics, we reduce the volume, and then patient will develop shock because a lot of volume is lost from the body. And then human albumin used in the symptomatic grossly edematous state. And then the definitive therapy, we give corticosteroid therapy. This is the main therapy for nephrotic syndrome. The type of the corticosteroid that used is a prednisolone. So in initial pre-episode of nephrotic syndrome, we
I
give
think Mr. Kim, yang ni apa nama ni, I think when you come to the year 5 nanti, then I think I expect you to know. So at least at this stage, year 3, you tahu the management, the first line is corticosteroids. Okay, so that's all for your level. So that, otherwise you become confused. Okay, any more?
Complication.
Okay, go on.
This is steroid-assisted nephrotic syndrome. Later you can read by your own. Next. This is a complication of the nephrotic syndrome. The first is thromboembolism, because as you know that the proteinuria cause a loss of the protein. So one of the protein that lost is a coagulation factor. So the coagulation factor also lost from the body, and hence it will cause thromboembolism. Second is a pulmonary edema, because the other spaces either from peritoneum or the interstitium is the pulmonary space, the alveoli space. So the fluid also escape into alveoli space and cause pulmonary edema. And then peritonitis. Peritonitis is because patient lost immunoglobulin. So when patient lost immunoglobulin, it will cause the infection happen. This is peritonitis. This peritonitis, nephrotic syndrome, is a primary cause. There is a primary and secondary cause of peritonitis. So in nephrotic syndrome is a primary cause of peritonitis. Next is hypovolemic shock. Patient, because the fluid loss into the third spaces, so patient might hypovolemic. So it may continuously and then become hypovolemic shock. And then patient may develop acute kidney injury and infections. I think that's all from me. Thank you.
Okay, so that was very good, Mr. Kim. So if I can just summarize nephrotic syndrome, okay. So we mentioned earlier that nephrotic syndrome is present in not only in children but also in adults. Okay, but in terms of the type of nephrotic syndrome in children is what we call the idiopathic nephrotic syndrome, which is primary, whereas in adult is mostly secondary. And if you talk about in Malaysia, the most common one is diabetic nephropathy causing nephrotic syndrome. Okay, and we have gone through the criteria for diagnosing, and we have mentioned about the concept of underfill and overfill. So I hope all of you can go through on that. And I think Mustaqim has mentioned about what are the approach when the patient comes with edema. In general, urine color, the family history, the ingestion of medication, over-the-counter medication, and so on. And then the investigation, we have discussed the investigation, whether you want to rule out whether you want to confirm the nephrotic syndrome or you want to rule out for secondary nephrotic syndrome. And then the management depends on what type. Are you talking about the underfill or overfill manifestation? As I said, majority of the time it is overfill, which means euvolemia. Euvolemic ataupun some of them may have hypervolemic. Okay. So the non-pharmacological, which includes the low-sat diet, the back, dia panggil immobilization. Maknanya you don't want nephrotic syndrome to be on the bed. Okay, it's not bed rest, it's immobilization because the risk of thrombosis. Okay, you worry, nephrotic syndrome, I want my patient to move around, not sitting on the bed, because otherwise they will develop the DVT, they will develop renal vein thrombosis, they also can develop pulmonary embolism. And the complication in nephrotic syndrome, the most common one is actually peritonitis. Okay, as you said, peritonitis in nephrotic syndrome mostly is a primary, which means that being nephrotic syndrome, they are prone to develop infection because loss of immunoglobulin, they also lost their complement, so that put them at risk to develop infection. Satu. The ascites itself is actually the possible source for the organism to actually grow. That's the second reason. Third reason is the immunosuppression that we use, the treatment, put them at risk as well. Okay, the immunosuppression, the name is immunosuppress. You want to reduce the antibody, so that's why patient at risk to develop infection. And the second complication that common in nephrotic syndrome is what we call hypovolemia, shock. Okay, and we have discussed the underfill, so that's along that line. The third one, thrombosis, is because, as you said, because of the either immobilization or because they lost the protein C, protein S, the antithrombin 3. So all those things actually lost in the urine. Okay, AKI is mostly due to hypovolemia. That's the reason they develop AKI. Okay, so the management, the steroids and so on. Okay, for general level, at your level, just know that the first line is corticosteroids. Okay, all right. Any question? Okay, we move on to the second case. Okay, well done, Apa nama ni Mustaqim. Thanks. Can we move on to the second case?
Doctor, can you hear me?
Can you turn on your video? Because otherwise I don't know who's talking. All right.
Doctor, I turned on already. Yeah, I turned on my video already. Can you guys see it?
Yeah. We can see you. We can see you. Yep.
Oh, okay, sure.
All right.
Okay. Good afternoon to Dr. Ikram and all of my fellow classmates. So I will discuss regarding the second case, and the second case is get from the internet and also the book. So this is not our real patient. So our patient is Ali bin Muhammad, 8 years old boy, and he is a Malay and live in Kubang Keriang, Kelantan. Next slide, please. And he come to the clinic with the chief complaint of shortness of breath and widespread hive for the past 30 minutes. Next slide. Next slide, please. Okay. So for the history of presenting illness, the patient have underlying history of asthma, well controlled for the past 1 month. The patient previously attended a family party, and the doctor is told by his parent that he ingested the chocolate peanut butter cereal bar, and after a few minutes, the patient complained of the difficulty of breathing and abnormal breathing noise on inspiration. The parents also noticed that his lip become more swelling and also red. Then the red itchy bump appear on the skin, which start to appear from the face up to the chest area. The patient also started to vomit, which is non-projectile and contains previously ingested foods, but no blood spotted in the vomiters. His father assists him by giving 2 puffs of the blue inhaler, the salbutamol, because the father suspected this is acute exacerbation of asthma. However, the symptoms partially resolved and his parents brought him to the emergency department. And this is her first episode of this presenting complaints. Otherwise, there is no bluish discoloration of the face, choking sensation, abdominal pain, loose stool, collapse, or urinary or bowel incontinence. And there is also no drooling of saliva and also no fever. Next slide, please. And for the systemic review, all are unremarkable. And next slide. Okay. For the past medical history, the patient is diagnosed with the asthma since 4 years old at the Klinik Kesehatan, and only one previous hospitalization during the first admission at 4 years old. He presented with the shortness of breath and treated with salbutamol, and there is no history of intubation in previous admission. For the past month, his asthma is well controlled on salbutamol inhaler, evidenced by no daytime symptoms, nocturnal symptoms, and need of reliever or exacerbation during the physical activities. Otherwise, there is no history of eczema or previous food allergy. Next slide, please. For the pediatric history, for the birth history, the patient is born full-term and spontaneous vaginal delivery with birth weight of 3 kg. And the antenatal history, intrapartum, and also postnatal are uneventful. And the immunization for this patient are up to age. For the developmental milestone, it is also up to age and there is no developmental delay, and the development is similar with other siblings too. For the feeding history, the patient is exclusively breastfed until 6 months, and he start weaning at 6 months and currently on normal adult diet. The patient has a good oral intake, tolerates the solid food, and there is no non-food allergy before this. And the patient weight is 27 kg, which is below the 75th percentile, and his height is 130 centimeter, below 75th percentile as well. Next slide. For the drug history, the patient is currently on salbutamol inhaler and is taken when needed, and there is also no non-drug allergy. Next slide. Okay, so for the family history, there is strong family history of asthma in which his mother and sister are having the asthma before this. His father has eczema and allergic rhinitis, and there is no consanguineous marriage, and he is the second out of the 3 siblings. The patient have an older brother, which is 11 years old, and a younger sister, which is 5 years old. And there is also no history of chronic disease such as hypertension, diabetes, and running in the family. Next slide, please. For the social history, the patient stay at Kubang Kerian, which is 5-minute drive from the nearest hospital, and he stay with the parents and also siblings. His father, Encik Muhammad, 38 years old, is a teacher at the secondary school, while his mother, Siti, 36 years old, is a housewife. He received his education at SK Kubang Kerian, and the house is equipped with electrical and also clean water supply. There's no smoker in the family, and no pets at home, and no exposure to the industrial and domestic dust or fumes at home. Next slide, please. So this is the physical examination. On general examination, for the mental status and general condition, the patient is alert, conscious, and there is a respiratory distress evidenced by the increased breathing effort, stridor on inspiration, and also chest wall recession, usage of accessory muscle as well. The patient talk in words, but the voice is hoarse, and nutritional and hydrational status look adequate for this patient. There is no obvious deformity detected and no attachment on the chest wall. For the vital sign, the heart rate is 122 beats per minute, and the patient is tachycardic according to the respiratory rate and also the heart rate chart. And the respiratory rate is 25 beats per minute, which is a tachypnea. And for the patient radial pulse, it is a regular rhythm and also adequate volume. The capillary refill time is within 2 seconds. The blood pressure is 96 millimeter mercury over 57 millimeter mercury. And the blood pressure is within the 50th percentile. And sorry, for the return to the previous slide. For the anthropometric measurement, the height is 130 centimeter within the 53rd centile, and the weight is 27 kilogram within the 55th centile, and the BMI is 16 kilogram per meter square within the 54th centile. So the patient is thriving. For the examination of the neck, the face, and also the limbs, the patient's skin is warm and dry, and there is normal capillary refill time, no clubby, no peripheral cyanosis, no muscle wasting present. For the face, there is tongue, lip, swelling, and red bumps, the rashes with scratch mark spreading from the face up to the chest area. However, there is no drooling of saliva or central cyanosis. For the neck, there is a swollen area and tightening of the throat. For the lower limb, the patient is warm and well perfused, and there is no cyanosis, but there is edema. So the edema is non-pitting in nature. There is a typo here. For the systemic examination, the patient, the CBS, for the CBS finding, the SYS2 heart sound is present with no murmur, and GI systems finding, the abdomen was soft and non-tender on palpation, and there is no hepatosplenomegaly. Start, please. For the specific physical examination, we examine the respiratory system. During the inspection, the chest moves symmetrically with each respiration. There is no chest wall deformity such as the pectus excavatum or pectus carinatum, no scars, no dilated veins on the chest, and the hive with scratch marks spreading in the chest area are present. For the palpation, the patient trachea is centrally located, the chest expansion is symmetrical, and the vocal parameters is equal for both lungs. And also the apex beat is palpable at the fifth intercostal space, which is normal for this patient. For the percussion was resonant and at all lung zones bilaterally. For the auscultation, the vesicular breath sound with stridor and echo bilaterally is heard, and there is no rhonchi or crepitation. Next slide, please. Next slide, please. Okay, thank you. So our diagnosis, our initial diagnosis is anaphylaxis. The diagnosis criteria of anaphylaxis, we refer to the Nelson textbook of pediatrics. So according to the textbook, the anaphylaxis is highly likely when any one of the following three criteria is fulfilled. The first criteria is the acute onset of the disease from minutes to the several hours with involvement of the skin or mucosa tissue such as the pruritus, the hive, the generalized edema, and also the swollen lips, the tongue, and also the uvula. And at least of the one of the following, the respiratory compromise such as the stridor, the wheezing, the difficulty in breathing, the bronchospasm, and also the reduced blood pressure or associated symptoms of an organ dysfunction such as hypotonia, collapse, syncope, and also incontinence. The second criteria is that the symptoms listed just now occur rapidly after the exposure to a likely allergen to that patient from minutes to several hours, and it might be also associated with the persistent gastrointestinal symptoms such as the crampy abdominal pain and also the vomiting. And the third criteria is the hypotension following the exposure to the non-allergen for that patient. And for the infant and children, the hypotension is defined as the low systolic blood pressure according to the blood pressure chart in the PIPS protocol, or greater than 30% drops in the systolic blood pressure. For the adult, the hypotension is defined as the systolic blood pressure less than 90 millimeter mercury and also greater than 30% drop from the patient baseline. So for the patient with anaphylaxis, the patient will present with the return to the previous slide. Okay. So for the patient with anaphylaxis, they will present with the airway problem, such as the airway swelling, the throat and tongue swelling, the hoarseness of the voice, and also stridor on inspiration. The breathing problems, such as the shortness of breath from the bronchospasm and also pulmonary edema. But this patient does not present with the pulmonary edema, wheezing, and also confusion caused by the hypoxia and also hypoxemia. Cyanosis is usually a late sign, and the patient can also present with the respiratory arrest. For the circulation problems, when the disease is severe, the patient can have shock, cardiovascular collapse with faintness, palpitation, loss of consciousness, and also cardiac arrest. and other considerations such as the positive or negative skin or mucosa changes. Next slide. So for the pathogenesis of this anaphylaxis, so
Good afternoon, doctors and my fellow friends. So, can you guys see my annotation?
Yeah. Yes.
Okay, good. I will continue the presentation with the pathogenesis of anaphylaxis. Basically, there are two main pathways for the anaphylaxis, which is the immunologic and non-immunologic. For the non-immunologic, it mainly due to the
Can you,
exercise.
Emilia? Can you
Yes.
annotate the screen?
Yes,
Can you annotate?
can you see my
You click
annotation?
on your. I don't see your cursor. I don't see your pointer.
Do I need
You,
to do that?
yeah. When you're talking about this type of algorithm slide, you can do that. So left, on your left hand side, there will be
Yes.
the annotation. There will be annotation.
Yeah, can you see this annotation? The
Ask to annotate. Ask to annotate
I
on the
have
left hand side.
yes, can you
I
see?
cannot see. Okay, yeah. Okay, fine. Okay, proceed.
Oh, okay. So there are two main pathways, which is immunologic and non-immunologic. And then for the non-immunologic, it is mainly due to exercise or other environmental factors. For the immunologic, it can further subdivided into the IgE dependence and IgE independence. For the IgE independence, it is due to the complement activations, whether there's indirect or direct. But among all these three, the most common one is still the IgE dependent anaphylaxis. And the allergens involved are such as foods, drugs, insect sting, insect bites, and latex. So in this pathway, it involves two times of exposure to the same allergens. In the first exposure to the allergens, the antigen presenting cell will present the antigens to the helper T cells, and this helper T cell will stimulate the B cell to differentiate to plasma cell and produce the antibody IgE. And this IgE will bind to the receptor on the mast cell and sensitizing them to the antigen. And then in this first time of exposure, sorry for the noise. In this first time of exposure, the patient might not showing any significant reactions to the food. So in the history taking, maybe the patient tell you that the patient do not have any allergic to the food before this, because the first exposure they don't show any significant allergy reaction, and then during re-exposure, which is the second time exposure to the same allergen, the antigen will cause the cross linkage of the IgE and the receptor on mast cell, and this time it will cause the inappropriate mast cell activations. Within seconds to minutes, the mast cell will undergo degranulations and release the preformed mediator inside the mast cell. And this mediator include the histamine, prostaglandin, leukotrienes, and the bladder activating factors, trypase, and new tumor necrosis factor. And then within minutes to hours, they will enter the late phase, and there's additional productions of the inflammatory mediator. These include the cytokines and the chemokines. And all these inflammatory mediators will cause the vasodilations, and this will reduce the peripheral resistance and cause hypotension, increase vascular permeability, which causes the plasma leakage and decrease the blood volume. And it will also cause the smooth muscle contraction in the airways, which is bronchospasms, and causing difficulty in breathing, and increased mucus secretions, recruitment of the inflammatory cells, and NS activations. So these are the pathogenesis of anaphylaxis. Next. Can you hear me? Next. Okay, so there are some differential diagnoses that share some similar symptoms with the anaphylaxis. First one is epiglottis. The relevant positive is acute onset stridor, and there's lethargic, Can you see my annotation?
Cannot.
Okay.
I can move your cursor lah. I can see your cursor just now.
Okay.
You can use your mana? Where is your cursor?
So for the relevant positive, the epiglottis also will have acute onset stridor, lethargy, and some inflammations or swollen throat. But in these cases, we rule out the epiglottis because of this absence of toxic appearance, and the patients don't have any cough, don't have any high-grade fever, and don't have any drooling in the history taking. And this patient have hive, which is the skin changes, but in epiglottis, normally they don't show any skin changes. And also the patient don't loss of voices, just that the patient have hoarseness of voice. And then for the foreign body aspirations, it is the relevant positive is also the acute onset stridor, and there's no fever, there's hoarseness of voice. But we rule out this because we don't find any foreign body during physical examinations, and we normally foreign body aspiration don't show any skin changes. And for the croup, it is also similar of the because of the acute onset of stridor, and there is hoarseness of voice. But in these cases, the patient don't have any fever, barking cough, no any retractions of the lower ribs, no tracheal tap, and no nasal flaring. And it is the same that the patient showing hive that croup didn't show. Okay, for the next slide. Okay, and then as we know, the patient have the history of asthma, so we need to include the asthma exacerbations into our differential diagnosis. So for the relevant positive, the patient showing acute worsening of the asthma symptoms, and there is wheezing, and asthma also caused by some other allergens. But in this case, the patient didn't have any persistent cough, and as we know, the patient father gave him the inhaler, but the symptoms fail to respond to it. So this can help us to rule out the asthma. And at the same time, the asthma will normally show the edema, but these patients are having hive. So these are the relevant negative for the asthma exacerbation. Next slide, please. Okay, for the investigation, normally for the diagnosis of anaphylaxis, doctor will diagnose it using the clinically based on the history taking, but not any investigation because it need acute management, right? But we also can do this serum tryptase level and test because serum tryptase, it will have a peak at 1 to 1.5 hours after the anaphylaxis, and if it is elevated, it will be helpful for us for the diagnosis. But if the tryptase level is normal, it still do not rule out the diagnosis of anaphylaxis. And then we also can do the skin prick test to confirm what are the allergens to this patient so that he and the caregiver can avoid it in future. Okay, next slide. For the management, firstly, if the patient at home, first one must be called for help, and then we will remove the allergens. If the family member or the people around the patient do not know what is the allergens, just remove everything. Then we need to assess the airway, breathing, and the circulations. And then we try to give a high flow oxygen, either giving high face mask, or if the patient really cannot breathe, then we need to consider the intubations and so on. And then we also use the intramuscular adrenaline. So if the patient have previous history of anaphylaxis, normally the hospital will prescribe the adrenaline pen for the family member. But in this case, the Ali is first time experience this kind of condition. So it will be given the intramuscular adrenaline in the hospital. Because the patient is 8 years old, we will give 10 microgram per kg adrenaline. And then if the patient do not have any response, we will repeat it after 5 minutes. And then the next one, we will give the crystalloid. And then it is to prevent the, because the blood volume is very low now, we need to prevent about shock. And then we will give antihistamine and hydrocortisone. For this hydrocortisone, it is either given intramuscular or slow intravenous. And we will also give inhaled bronchodilators. So if the patient fails to respond, we will repeat the bronchodilators. And if the patient condition has been stabilized, then we will continue to monitor the patient with the pulse oximetry to check for the oxygen saturation in the blood, ECG, and blood pressures. Normally, the continued observation will be about 6 to 24 hours so that we can prevent any complications or any recurrence of the conditions. And next. Before we discharge the patients, we need to consider about further episode. So we need to educate the patients and the caregivers, like in this condition, after we confirm what are the allergens, whether it is peanut in the peanut butter, we need to tell them to avoid this peanut, anything that contain peanut in the futures, and what are the acute management they need to do when the patient showing the same allergic reaction again. And then we also need to manage of the comorbidities in this condition, which is the asthma. And for the fourth one, we need to give the patient the adrenaline pen, because the patient are having asthma and the patient have been showing the history of anaphylaxis now. So it is very likely for the patient to have this kind of reaction if he exposed to the peanut in future. So we need to give the adrenaline pen. Next. So these are the complications. First one is the hypoxia. So because as we know, the blood volume is very low and the patient is having breathing difficulty, and the shocks due to a low blood volume and myocardial ischemia, mainly due to the hypotension and the hypoxia and arrhythmia. And the fall or other injury from the syncope, because the patient might have hypotonia or fainting, so the patient might have fall or other injury. And brain injury mainly due to the prolonged hypoxia and even death. So I think that's all of our presentations.
Okay, that was good. So basically we cover both the edema as well as shock management. Okay. Okay, so I think just a recap to in both cases. So when a patient comes with edema, as in the first case we have commented, so it can be renal cause, which is the most common one that you want to look for is nephrotic syndrome, or it could be other nephritic condition. And the other organ is liver disease, as Mustaqim highlighted, liver disease, cardiac failure, allergic or anaphylaxis. Okay, and also the cardiac condition and also liver condition. So as for the allergic or anaphylaxis, okay, so just now we were describing on the a child who actually developed the edema after ingesting the peanuts. Okay, so if you do not diagnose the edema is because of the allergy, okay, so patient may actually progress into anaphylaxis. So that's why it is important to actually diagnose it early. I always told the junior doctors that all edema is not always nephrotic syndrome, see. So we have quite a few patients who came with proteinuria and edema. So it was labeled as nephrotic syndrome, but it actually turned out to be allergic reaction. So I think Emilia has highlighted to you the difference between the allergy and anaphylaxis. Okay, so as I said, if allergy reaction, then it's usually the blood pressure is bad. Okay, patient just have the localized reaction, periorbital edema. They may just have itchiness, urticaria rash. But the moment the blood pressure start to actually compromise, patients start to have vomiting, patients start to have giddiness. So that's not a good sign. So they may have already progressed into anaphylaxis. So your management would be have to be aggressive the moment they actually even at the first presented with the allergic reaction. Okay, so once you conclude the patient has allergic reaction, yes, corticosteroid will be the management in those patients. Remove the allergen as you highlighted. Of course, the airway breathing circulation has to be there. Adrenaline is very important. Okay, so the moment usually those actually in the allergic reaction, you don't need to comment on adrenaline. But once they actually start to show evidence of anaphylaxis, vomiting, BP, white pulse pressure, patients start to have cold peripheries, then really you have to give the adrenaline. So it can be given either IM or IV, but IM has been shown to be more effective in patients with anaphylaxis. Okay, the rest antihistamine and also the fluids will depend on the clinical state of the patient. Okay, so I hope after now all of you have the ideas. We only managed to discuss two conditions, renal and also the allergic or anaphylaxis condition. The other two, liver disease and also cardiac condition, you have to read on your own. Okay, so any question before we actually wrap up the session? Okay, hope all of you still awake.